Please introduce yourself.
Did you ask me to introduce myself?
No, sorry, Renee. Could you
Oh.
please introduce yourself in a minute?
Sorry. I'm Renee Bolio-Banks. I'm one of the elders and residents at the Native American Community Clinic. It's nice to meet all of you. Miigwech.
And thank you. And Donna, would you introduce yourself as well as one of our team?
Yes, I'm Donna LaChapelle, the other elder here at NACC, and I'm glad to be here. So thank you all.
Rich. Dr. Meyer, would you introduce yourself?
Bonjour, I'm Laurel Myra. I am the director of Minnow Bidiziwin, and we are a partner of NACC, and we serve the metro area as well and partner on a lot of the chemical health and behavioral health area. Welcome.
Rich. Michelle?
Hello, I'm Michelle Corcoran. I am the nurse manager at the Native American Community Clinic MAT program. Welcome.
Rich. Tina?
Hi, I'm Tina. I am the HIV case manager at NACC.
Hi, I'm Beth Ryan, and I'm the Project Echo coordinator at Hennepin Healthcare and for NACC.
Rich, thank you. So I'm going to go ahead and pull up the slides. One moment. Oh, and I'm sorry, I didn't have Nikki introduce herself.
I can just introduce myself when I start presenting.
Oh, thank you. Back. All right, so today, this is our agenda for the Midwest Tribal Echo today. Renee did the prayer and land acknowledgement. Thank you very much. I'm doing the introductions and agenda. I'm going to go through Zoom guidelines. Michelle will be doing our announcements. Nikki Giardina will be doing our didactic today, which is on safer use education. Dr. Graham will do the case presentation if we have time, and then we will close. So as far as Zoom goes, please introduce yourself in the chat function. Name, title, organization, email, so we know who you are. You can update your name on the screen, right click on your image and rename it. We prefer if everybody turn on their camera. It's nice to see everyone. It's helpful, especially if we're having a discussion, and so we all feel like we are connected. Please mute your microphone when you're not speaking. If we might mute it if we are hearing background noise, so please don't take offense if that happens. If you would like attention, use the chat or the hand raise function, and as always, no protected health information. Michelle?
All right, for announcements, as usual, a reminder, we meet the first and third Wednesday of every month at noon. Next sessions are going to be in July, which is hard to believe we're already there. So on the 7th, we're going to be talking about peer support services with China Pfeiffer, who is a peer recovery specialist here at NACC. And then on the 21st, Healthcare for the Homeless, which is a Hennepin Healthcare program, is going to join us to talk about mobile outreach for HIV, Hep C, infectious diseases, things like that. There's some other echoes that are kind of, I guess, affiliated with Midwest Tribal Echo. There's a viral hepatitis echo and an integrated opioid and addiction care echo. Those are hosted by Hennepin Healthcare. And you can reach out to us or Beth, who has joined us here, if you have questions, want to know more, and certainly go to the Hennepin Healthcare website to access additional info. Next slide. Case presentations. We don't usually have time for these, but you're welcome to send something in. And if you don't want it to be a formal case presentation, that's fine too. If you just have a patient you're struggling with, or something that's going on in your care, then feel free to reach out and we'll help as best we can. Next slide, and I think that's it. And there is no CME today for this particular session, so apologies if you were hoping to get CME credit, but there is none today.
Thank you, Michelle. Nikki, if you'd like to introduce yourself and start your presentation.
Sure. Well, thank you so much for having me. I'm really honored to be here. And my name is Nikki Giardina. I'm a nurse and I work at NACC, and I've been working in harm reduction. I started working in a syringe exchange about 15 years ago, probably, maybe a little more than that. And I've worked at a few different syringe exchanges since then, and healthcare settings that work within a harm reduction philosophy. So NACC has definitely been the sort of culmination in terms of my experience of everything that I've been interested in. It's all come together and been wonderful there. So I'm just so happy to be able to work at NACC and work with this amazing harm reduction team. And then I'm gonna share my screen. Okay. Does it look right to everyone?
It looks great. Thank you.
Okay, wonderful. So this presentation is going to be on safer drug use. It's not going to include very much theory. It's mostly going to be very practical steps to reduce harm when using drugs. And I'm going to use a lot of very just sort of frank and honest language about drug use, a little bit about sex. And if anybody feels like maybe they can't handle hearing that today, that's obviously you're welcome to leave. And I totally understand that. I just wanted to be very clear about that. I'm also not going to talk about fentanyl test strips. And I made that choice because I feel like that could be its own presentation. And I'm not an expert in fentanyl test strips. And so I bet there's someone, if you guys haven't done one already, I'm sure there's someone out there that could do it. But just be aware that that's definitely a component of safer drug use. And I just didn't have the time or the expertise to include it in here. And if anybody, if anyone like disagrees with anything I'm saying as I'm presenting, or feels like their knowledge is different than my knowledge, please feel free to like interrupt and share your knowledge too. So just to begin, kind of why is it important to talk specifically about ways to use drugs with less harm? So harm reduction philosophy says that people who use drugs deserve access to information that can help them take charge of their health and protect themselves and keep themselves well and keep themselves alive. And that abstinence should not be the only answer for someone who is using drugs and seeking services if that person is not ready. Anyway, I know I'm preaching to the choir here, but I just wanted to have said it. And it's good public health. There's just so much evidence that all of the components of harm reduction have a really positive impact on infectious disease, overdose rates, people's quality of life. And the evidence also shows that it does not increase drug use. So when we're talking about drug-related harms and risks, I just wanted to kind of quickly go over what some of them are, but there's more I'm sure that I didn't put on the list. So infectious disease, mostly HIV and hepatitis C are what we're going to be talking about today. Skin and soft tissue infections, damage to a variety of tissues, so damage to blood vessels, blood loss, nerve damage, sort of more serious infections, endocarditis, osteomyelitis, sepsis, overdose, of course, social and relational harms, and then criminalization. So, becoming part of the criminal justice system is a harm associated with drug use. I would also argue that it actually is the reason for many of the harms associated with drug use. So I think it's both, that one in particular is both an outcome and a driving factor for a lot of these, that if criminalization weren't driving drug use sort of underground into the shadows, that there would just be so much more access to all of this information, supplies, so that people could keep themselves healthier. So when we're talking about risks associated with drug use in harm reduction, a lot of times we're going to talk about a hierarchy of risk. So the idea that there's one sort of safest, ideal way to do something. I mean, that might be abstinence in a lot of cases. So the lowest risk way to approach drug use. And then there's a spectrum going all the way to the least safe option, or, the option with the highest risk. I just really liked this diagram. And so here they're saying never injecting is the lowest risk, and then sharing with other people is the highest risk. And then, we have everything in the middle. So being able to use a new syringe every time you inject is the standard for harm reduction injection practices. But then, if you can't do that, at least try to just be using your own supply. So a lot of things that we're going to talk about are going to kind of be along this spectrum, but it's not always that simple. And so we'll also talk about that, how it really can depend on the individual and what they're using and how they're using in the context of their use and their life circumstances. So this is sort of a good example of how it can be more complicated. These are a lot of different ways that people use drugs. I tried to sort of put them in a hierarchy of risk order, but in the middle it got very murky. And again, it just sort of depends. I would say that when somebody is using drugs in a way that delivers the drugs to their system the fastest, that is generally going to be a higher overdose risk. And then of course, anytime you're, damaging any tissues in your body or breaking your skin barrier, that's going to be a risk for infection. And so that's some of the ways that we can think about it. But because inhalation, so smoking and intravenous drug use are two of the highest risk and probably most common ways that we're going to see drug use, I'm going to focus mostly on those today. Okay, so first we're going to talk about injection. People can inject drugs in a few different ways. So they can inject intravenously, which is probably the most common. People will inject intramuscularly, so just the same way that you get a vaccine, inject right into a big muscle. Intradermally, sometimes people call this skin popping, and they'll inject a little bit of a drug under the skin. But mostly we're going to talk about intravenous injection because it's the most common. And I think it's important to talk about the benefits of it. Why do people choose this route in addition to the drawbacks? And just a note that a little bit of what I might talk about might sound like talking about how people can use so that they get the result that they want, use so that they are being effective and achieving the sensation of the substance that they're using that they were going for. And that may seem sort of counterintuitive. And my reason for doing that is because I think that if people are not well educated on how they're on using in an effective way, then they're more likely to use dangerous amounts, to use in a way that feels high stress.
Nikki?
Oh, yes. Sorry, what happened?
I'm not sure.
I'm sorry, maybe it's my internet connection. Suddenly you were skipping, but maybe it's just me. Sorry.
Oh,
I think it's the clinics because mine has been skipping too, and it said bad connection or something.
oh shoot.
So I'm sorry.
I'm at home and it's fine.
But don't worry, Nikki, it's us.
Don't worry about us.
Yeah.
You're doing great.
Oh, all right. Well, anyway, that if people are struggling to understand the basics of drug use, they're more likely to use in dangerous ways, is basically all I'm saying. And so, anyway, so that's sort of the logic behind that. But feel free to disagree with me and interrupt me. I'm totally open to that too. So, and I also just want to say, of course, harm reduction takes very, very seriously the real harms associated with drug use. So in no way is any of this trying to reduce that reality. It's, an attempt to keep people alive and in control of their lives and healthy, and to limit, infectious disease. And anyway, okay, so people inject drugs because it's efficient. The entire amount of the drug is going right into the blood. It's not being lost to the air or anything like that. So therefore it's more economical because people aren't having to use as much of a substance, and the effects come on very quickly. People will call that a rush, and they may last longer than some other methods. And then there's some pretty high risks associated with it too. So those include overdose, infectious disease, other kinds of infections, and then having to manage like a lot of equipment. And sometimes that equipment is illegal to carry around depending on where you live. So this is a really good example of the hierarchy of safety. When people are making the first choice they usually make when they're about to inject, which is where on their body are they going to inject. And so they need to find a vein, and generally arms tend to be the safest. And we're going to go over this in a little more detail on the next slide. But so generally we'd say hands are the next safest, feet and ankle and legs are getting riskier. Groin is then getting to the super high risk areas, and then the highest risk areas are going to be the neck, breast, and penis. And we will talk about all of these in detail. I just like this image, and I have a resource guide at the end that like links all of these. And so if anybody ever wanted to, a lot of times these are available to like print out as PDFs, so you can give them to clients or patients, or you can, you know, buy a poster from a harm reduction organization, something like that. So I think it can be helpful to give patients maps of where veins are likely to be in their body. The maps don't necessarily pertain exactly to every person's anatomy, of course, but it's better than not having any idea. Some tips that we want to give to people around safer injection is to always inject with the blood flow, so toward the heart. We like to encourage people to rotate sites, so to not inject in one spot over and over again. If they are injecting in the same vein more than once, to inject downstream, so closer to the heart than the first time. The idea being that if there's a blood clot from the first injection, that we don't want to then push that blood clot by injecting upstream from it. So, and again, arms are generally the safest. If people start injecting in the small veins of their hands and feet, those veins can very easily be damaged by, they can't take a lot of fluid. And so we encourage people to inject slowly, take their time. Hands can swell if they're injected into, and then there's an infection or a shot gets missed and just injected into tissue. And so we encourage people to take off rings before injecting, so that those rings don't cut off circulation. And then I think it's just important for people to know, if they're injecting in their legs and their feet, that if they wind up having an infection or pain or swelling, that can really limit their ability to be mobile. And so they may want to avoid that if they are someone who needs to be walking a lot or on their feet. So the groin is in this very high risk injection site, but it's a site that people, you know, do seriously use and sort of figure out how to use sustainably for a while, but there are pretty substantial risks associated with it, like developing DVT, a very serious blood clot in the lower extremities that can ultimately be fatal if it comes loose. The vein and artery are close to each other, so it's easier to hit the artery or accidentally nerves and cause nerve damage, or create fistula, so accidentally create a connection actually between the artery and the nerve. And then neck, neck, breast, and penis are sort of the, they're the most dangerous areas. The neck, you're really close to the artery, and there's just so many things going on there that you don't want to hit, you don't want to damage structurally, and you don't want to expose to infection, because it can really affect some of the most important functions of your body. Breasts are, the veins are very, very fragile. It's a really high infection risk. And then in the penis, if you damage vessels in the penis, then that can lead to a persistent erection. And I think that for a lot of these, something to keep in mind is that they can cause death, but they can also cause very serious health issues that will result in somebody having to seek emergency medical care. And I think a lot of people who are injecting drugs have had really negative experiences with medical care before. Maybe they have prior experiences of trauma or of being, really stigmatized in healthcare settings. And so that can kind of be a motivator to try to inject in safer spots. And I'd also say that once people are moving towards these areas, it can indicate that they've run out of other veins in other parts of their bodies to access, and that there's a little bit of desperation there. And so if somebody is sort of coming to you saying, I'm about to start injecting in these really dangerous areas. I know it's so dangerous, but I feel like I don't have another option because I can't find any other veins. What I would really encourage in that moment is to maybe talk to them about other ways of using, that can be sort of a harm reduction intervention in that moment, that maybe you want to start smoking instead of injecting, at least for a while, to allow your veins to kind of recover. So if the person is open to that. I'm noticing I'm running a little bit behind my own personal time frame. So I may sort of skip over things as I go, but also I think that everyone will have access to the PowerPoint. So you can go back, and things are pretty self-explanatory. You can contact me if you want to, but I knew it would be too long, but I couldn't decide what to take out. So we don't want to inject into arteries. It can do a huge amount of tissue damage. It's really dangerous. So people sometimes may think that injecting into arteries is going to give them a very strong effect of the drug, and that isn't true. When you inject into a vein, it's kind of, gradually flows throughout your body. But with an artery, I mean, it's just going to get pushed into a tissue, basically. It's not going to do what you want it to do. And so that can kind of be a motivating piece of information to avoid arteries. If somebody does inject into an artery or has a needle into an artery, usually it's going to feel very painful, and there's going to be sort of blood pulsing into the syringe. Sorry for the graphics. And it'll be bright red and frothy. In that case, we just want people to stop, pull the needle out, put pressure on the wound, try to hold it above the heart if possible. And if it, get medical help, but especially if it doesn't stop bleeding, because we really want we do not want an artery to be continuing to lose blood. And then I think that one of the most important things in injecting and kind of preparing and finding a vein is to have a space that feels safe. And, obviously this is such a privilege when people do, and is, one of the reasons that a supervised consumption space could be helpful in decreasing harms associated with drug use, because then people would have a place where they can sit down, take their time, feel calm and collected, make health-oriented decisions, where there's running water, where there's plenty of light, and where hopefully there's maybe someone else around who can respond in case of an emergency, and so that both people can help each other if necessary. So people, when they decide where to inject, they're going to try to find a vein there. And so some suggestions for how to make a vein more accessible would be, just general suggestions around this: hydration, putting, maybe some a warm compress on the area, exercise, putting the area lower, so that means dependence, so that there's more blood flow in the area. If someone feels a pulse in a specific vessel, do not inject there. That's more likely to be an artery. And then if somebody is in an active state of withdrawal and is maybe feeling very desperate to inject, sometimes, you might recommend sniffing or smoking just a little bit to calm down enough to make a good decision with the process of injecting. Everyone's seen this image before. I know it's over circulated at this point, but the idea of this is just that when you reuse needles, if they're your own needles, then there's not a risk of them being contaminated with someone else's blood. But the more you use them, the more damage they do to your tissues as you're injecting. And smaller gauge needles, so those are the ones with the higher numbers, 29 gauge, 30 gauge, those are really skinny needles. And it's clear why people would prefer to inject with them. It's much easier to find a vein, but those do blunt and come apart like this faster. So a needle like a 27 or a 28, it may, if you're going to be reusing your own needles, it may stay in better shape for longer. And then we also want to make sure, if we're working directly with people who are using needles, that we have, answers to questions like, well, if I want to inject into my muscle, what kind of needle should I use? That sort of thing. So just, knowing a little bit about what different needles are for. These are just all the different pieces of equipment that people might use when they're injecting. We've probably all seen these before, and we'll kind of go through them as we talk about the process. But, we just want to make sure that everything is as clean as possible. Washing something, it's better if it's new. So if you're using a cooker, it's better to use a new cooker. But if you don't have a new one, it's better to wash it. We also like to tell people to cover the surface. You could take newspaper and cover the surface you're preparing a drug on, because if someone else has injected there could be invisible hepatitis C on the surface that then could get on your supplies, basically. So, and I don't think we all need to be walking around nervous about hepatitis C on surfaces all the time at all, but it's when you're actually doing sort of a blood to blood, you're actually going into your veins and putting something there. That's when I would be that concerned about it. People dissolve their drugs in water if the drug is not already liquid. Sometimes an acid is necessary, although I've been hearing that that's less and less true with heroin that's available now. But if an acid is necessary, there's like vitamin C packets that can be used for that. We want to discourage people from using like lemon juice because it can create, putting sugar into your vein can create, a lot of risk for infection. This is just a visual on how to tie a tourniquet. We don't need to learn how to tie a tourniquet right now, but it's just an example of the kind of thing you could potentially offer someone if they are, learning and at risk of doing it incorrectly. So this learn how to inject yourself isn't meant for the audience necessarily. What I mean there is that, sometimes people who do not know how to inject themselves are then dependent on other people to inject them. And I think that sometimes that can exacerbate existing dynamics of abuse or control or power imbalances in relationships when one person in a relationship is dependent on another person to inject them. So I think learning how to inject oneself can be empowering in that way and can make a person less dependent on a relationship if that's something that they feel would benefit them. When people inject, we want them to have the bevel up. So the bevel is, the needle has a hole in it, and then the opening goes kind of like this. And so we want it to be with the bevel up at about a 45-degree angle. And then when people inject when people think they found a vein before they inject, then we encourage them to register, is what they call it. So you pull the plunger back a little bit, make sure there's blood there so that you're injecting into a vein if that's what you had intended to do. When you're dissolving the drugs in water, this is a really good example of the hierarchy of risk. I know this is hard to see, so I have it blown up in other slides. And I have this linked if anybody wants to access it later. But so the very safest water to use for injection drug use would be an unopened ampule of sterile water, which a lot of syringe exchanges do hand out. If you don't have that, you can boil tap water and then allow it to cool, and it should be recently boiled water, and don't inject boiling hot tap water, definitely. So it's got to come to room temperature. But also fresh cold tap water, if it's safe enough to drink, if you don't need to boil it before drinking it, depending on where you live, then it's a low risk of carrying bacteria or other pathogens in it. Hot water is slightly higher risk. Bottled water is probably less clean than tap water, depending on where you live. And if somebody has had a drink out of it, then it is likely pretty contaminated with bacteria. But then we're getting into higher risk, and this is anything shared. So anything that anybody else has dipped a needle into, because if you dip a needle that's been used into water, or a used cooker, then that can then deposit some old blood into the water, which can carry hepatitis C. So same with a used ampule. So actually tap water is safer than a sterile ampule that's already had a needle stuck into it, if that makes sense. Sometimes if people are very desperate, they may resort to using toilet water. And so we like to tell people to use tank water instead of water from the bowl, or if they're using water that they're, finding on the ground, that running water is safer than standing water. I mean, I hate even saying these things, it makes me want to cry. And I think my hope is just that, there's low barrier ways to access other water options, but this is sort of the education we want to give people so that if they are in that desperate situation, they have choices. I want to talk quickly about hepatitis C specifically related to IV drug use, because it's so common amongst amongst people who inject drugs, because they are doing that sort of blood-to-blood contact if they're using used supplies to inject. And hepatitis C is easier to contract than HIV because it's smaller and it lives longer outside of the body. And one of the, using all of your own equipment is one of the most important ways to avoid hepatitis C. Labeling your equipment, and if you're sharing a shot. So if someone's preparing a shot and then splitting it between two people, we want to give people information on how to do that safely. So you use one clean syringe and then deposit it in the end of the two used syringes, so that people's blood is not ever overlapping, you know, and it's a little bit complex to figure out the order. And so I have links to all of these materials if people want to give them to clients or use them to further educate themselves. These are some examples of ways people can mark a syringe in order to make sure that they know it's their own if they're in a space with other people who are also using syringes. I like the idea of scratching off a number, like everyone has a number and then you scratch off whatever number is yours. I thought that sounded easy. Oh, time check. Okay, I'm pretty good. So bleach, people sometimes bleach needles if they don't have new needles, and I think it's important to know about it, but you know, it's not really recommended. We don't really, in very controlled laboratory settings, bleaching needles, bleaching syringes, I mean the whole syringe, does seem to kill HIV and hepatitis C, but not in real life, not in community settings. Studies have shown that people, for whatever reason, you know, the context of people's real lived lives, it doesn't seem 100% effective. So, but I do think it's important to kind of know about it, you know, and it is a harm reduction technique. Certainly it would lessen the presence of viruses and bacteria in the syringe. So I won't go over this now, but this is instructions for how to bleach a syringe. So I want to kind of veer away from intravenous use into some other routes of drug use. And so this is sort of a general list, and it again, it has this highlighted the speed at which different drugs you'll feel the effects of them, which has a lot to do with risk and also a lot to do with how people choose to use different drugs. And I want to point out, and we'll talk about meth at the end, but I want to point out that meth is unique because it's very, very, very damaging to tissues, to human tissues. And so whereas people can inject opiates into the muscle, for example, for slower absorption, you really can't do that with meth without damaging yourself. And so we really discourage people from injecting meth into the muscle or under the skin. And people do inject meth intravenously. And so the idea is to not miss and accidentally inject into other tissues, which the meth will damage. And then, you know, some people will use meth in a way that's colloquially called booty bumping. And there might be like a new term for it. Booty bumping might be outdated, but that's the term that I know. So that's when people inject dissolved meth into the rectum. And so it's absorbed in a similar way to when you're snorting a drug, that it's absorbed through the mucous membrane into the blood vessels. And the thing to be aware of with meth is that, and it depends obviously on what communities you're working with, but if there's anal sex being paired with the meth use, then that inserting the meth into the rectum is going to make that person, the person receiving in that sexual encounter, more likely to have a transmission of an infectious disease to them, because the meth has made that tissue very, very vulnerable, because it's damaged it, and also meth in general constricts vessels. It's an antihistamine, so it reduces secretions, and so it just makes your body it's taking away some of your immune system, basically. It's making your body vulnerable to infection. Okay, but we're going to talk about smoking. We'll go back to meth a little bit at the end. So why do people use it? It's very rapid onset, more rapid actually than injection generally. And it's easy. You don't necessarily need a lot of skill or a lot of tools to do it. It is a risk for hepatitis C. So people who share pipes, mouthpieces on pipes, can transmit hep C that way. It can cause inhalation and ingestion injuries, cause sores and burns on the mouth and throat, and it is a risk for overdose. So we're going to talk about crack cocaine and meth smoking specifically. So safer crack smoking, and I really encourage you to go to these these resources that I have linked at the end and look around. I mean, there's just like so much really well researched and I think well-designed education for the public and for people who use drugs on this. And most of it, I think, has been developed by people who use drugs themselves. And so it's very driven by lived experience. But so when people smoke crack, the pipe is straight. There'll be a separate mouthpiece. We want people to use separate mouthpieces so that they're not having that blood to blood transfer if they're sharing a pipe. Screens are kind of what it holds the drug on one side and then, filters it so you're just inhaling the vapor and not the drug itself. And a push stick helps to push the screens into the pipe. Lip balm and gum help too because they just help to create more of a barrier on the lips and in the mouth with gum, keep more saliva there so that it's less likely that there can be transmission through the mucous membranes there. So we'll go kind of quickly through this, but people can look into this more on their own. There's lots of information on tips for how to load the screens into the pipe that you're using because it can be a little tricky. Let's see. So for mouthpieces, those showed glass mouthpieces, but people can also use rubber. They can actually use rubber bands or like a spark plug cover. We really encourage people to throw away pipes and mouthpieces that are broken because they can cut lips and increase the risk of infection. And if people are sharing a mouthpiece, at least they can clean it or use an alcohol wipe on it and then put Vaseline on their lips again to create that barrier. And then people who are using pipes that weren't created for smoking run the risk of inhaling like noxious fumes. So this is an example of putting gauze into a crack pipe. And then screens is what we call it. They call it gauze here. I think this might be Canadian or British, which is why they're using a different word for it. But when they say gauze, they mean screens. People sometimes use steel wool for that. And so, it's a harm reduction intervention for people to actually use screens intended for smoking. And so they can get those from needle exchanges or from smoke shops. Steel wool can come apart and then you can wind up inhaling little pieces of it, which is very damaging. If people are using steel wool, we like to encourage them to find a kind that doesn't have like a cleaning agent added to it so that they're not also inhaling that. And then meth is used in a similar way, usually with a pipe, something that's sometimes called a bubble. It has this sphere on the end that holds the drug. And this is just repeating everything that I said already before about meth, but just to take some steps to try to sort of protect your body, protect your mucous membranes, because they're going to be very dry and vulnerable. I wanted to talk about a couple of special topics briefly that are definitely pertain to risk reduction around drug use, but that could be presentations unto themselves and that I just didn't have time to get into, but I wanted to make sure we kind of touched upon them. So wounds, I mean, this is definitely not a wound care training. And I actually think when healthcare for the homeless presents in a couple of weeks, they're probably going to talk about wound care and that's going to be amazing. And they're brilliant in that area. So but I just wanted to say that obviously wound prevention and wound care and wound self-assessment are steps in harm reduction around drug use. And so people having that knowledge of how to assess a wound, how to recognize the signs that mean you really should go see a doctor, and then the signs that mean you need to go to the emergency room right now. And so those really dangerous signs are generally signs of the infection moving past the wound and becoming either systemic, so somebody is feeling ill, which might mean that they're that they have the potential for it to become septic, for them to go into septic shock, or that it's affecting a vital organ. So endocarditis, for example, if somebody is feeling short of breath and has had a wound or it does inject regularly, it could be a sign, or is having chest pain, it could be a sign that they are having an infection of their heart. So overdose prevention is obviously another way to prevent risks associated with drug use. So, just the encouragement is to get trained, carry Narcan, know how to use the Narcan. And I'm sure people, and Narcan and naloxone are the same thing, by the way. Sorry, one is just the brand name. And I think most people have heard most of these in trainings that they've done, but just a quick overview of risk reduction around overdose. So people are much more likely to overdose after periods of sobriety. So they might have been in treatment, detox, incarcerated. Even if it's a brief period of time, their tolerance goes way down. So if they use the same amount of a drug that they use, and I apologize if this is repeating things that everyone knows, but I just think that this particular point is so important, that if they use an amount of drug they were able to use previously that was an appropriate dose for them, it may be too much and it may basically overwhelm their system, and it's a risk for fatality at that point. So using with someone else is such a great way to prevent fatal overdose, because then people can respond in an emergency. Never use alone is a service where someone stays on the phone with you and makes sure you're responsive throughout the course of using. So I think that that's a great resource to explore. PrEP, so pre-exposure prophylaxis, so taking antiviral medication in order to prevent the transmission of HIV before you're transmitted. And so so that's a great risk reduction strategy for some folks, and especially people who are injecting. And the key is just having low barrier access from non-judgmental providers. And then in terms of providing this kind of education, I just wanted to say a little bit about sort of what I've seen that seems like it works really well is, just including some info with supplies, making sure that info is written at an appropriate reading level and using language that is appropriate for the audience, just like of any other written healthcare education, basically. And then putting info on little things that people like and use and like to collect, so like matchbooks or lip gloss, something like that, sort of making it helpful to somebody's day-to-day life. Having peers, people with lived experience of drug use, really leading the creation and distribution of education is essential in harm reduction. Yeah, and then of course the biggest way to reduce harm around drug use is focusing on those major factors like lack of housing and really focusing on what is it that the patient or the client is saying are their priorities. So this is a resource list, and some of this stuff is just so amazing. So I don't want to start clicking on it because I'm afraid we're going to get lost somehow in the internet if I start going between different websites. But so these first three are manuals. This one, Getting Off Right. I don't know if you can see if I have a pointer, but this third one here, Getting Off Right, is sort of a classic. It's old, but it's still accurate. I mean, if you're seeing it contradict with something that's new, then you could do a little bit more research, but it's just brilliant. And then these two are newer, Take Care, Take Charge, or Safer Injection Handbook. Tweaker.org is a website that is specifically, so it's a harm reduction website, and it's specifically geared towards men who have sex with men who use meth. So it may not be sort of culturally geared towards everyone, but it has such good information, and I think that information can easily be used in other contexts. I take information from there all the time and use it in other contexts, and I'm not often working with that population specifically, and so it's just a wonderful website, and I think really they're just great harm reductionists. They're just really practicing harm reduction. A link to the injection water risks poster, Safer Drug Use 101, sort of a quick guide, which is nice. It'd be a nice thing that people could kind of grab and go from your organization. A couple of videos. So this first video is from the Harm Reduction Coalition. It's about safer injection techniques. I think was maybe created by a group of young adults or something like that. And then this video of safer crack smoking is done very well as well. This is a link to all those visuals on safer crack smoking and safer meth smoking, that how to fit gauze into a crack pipe visual. And that is all that I have. So I'm happy to answer questions. And then I don't know if we have if there's a case also. So that's all I've got.
We won't be doing a case today. If you unshare your screen, and then we can take questions. There you go. So thank you very much, Nikki. That was really great to have that in one place. Does anybody have any questions or things they want to talk about related to this?
I have a question. I guess I wonder, this is very helpful, by the way, thank you for sharing with us. Thinking about a community where there's families and young children. I'm thinking about an apartment building and like a small community area. Are there any suggestions that you have of how to kind of increase the safety of the community, but also, not make people feel like they're ostracized or, not welcome in their own like home or community?
Mm-hmm, mm-hmm. Yeah, and so you're saying like in a setting where it's not just serving people who use drugs, where there's, yeah, I mean, I think NACC is a good example of that sort of, and yeah, I mean, so what, I guess I'm interested if like Michelle or Dr. Abby or Tina have anything to add to this, just in sort of from the being in the clinic. I think that yeah, I mean, I think that having ways for people to request services that are low key, that don't immediately put like a big blinking light over their head, but that also aren't shrouded in shame. So something sort of straightforward, like ask the front desk, to see so-and-so, and we'll kind of understand what you mean, that sort of thing. And I think potentially doing some wider community education sort of around harm reduction could be helpful. And I think also giving folks an opportunity, the tools that they need to be responsible community members. So, I mean, if you have a community with families and children, and those people are concerned about the presence of people who use drugs for specific reasons, I mean, how can we make it so that those reasons don't exist? So can there be very, very easily accessible sharps containers so that there aren't any sharps containers being found in the community? And then can there be the presence of safety protocols, basically, in order to prevent overdose from happening? So can there, if there's staff, can there be staff sort of checking on people in non-judgmental ways? Can there be naloxone available just to sort of prevent sort of like communal experiences of trauma from deaths? I mean, I think it's a question to definitely think about. It's a great question. I don't know if anyone, I'll think about it too if anyone has anything else to say.
One of the things that we do is we encourage people to, and we used to give, I don't think we have them right now, lock boxes for rigs and needle, and we do it for Suboxone, but also to give people a way to store their equipment and their drugs safely. I think is important. I also think it's important, if working with a community that's using injection drugs to make sure that we're addressing the issue of needles in the community. And so, like, for example, I know that Southside Harm Reduction and NACC has organized needle pickups and things like that. And then even further than that, when we're talking to families who have children and who are using drugs, we talk about making sure that they're not using alone with the children, that there's another adult to watch the children when they use them. And we talk about that specifically also around child protection, but just in terms of safety and making sure that the children, that, just like we tell kids, tell people to cover their outlets in their room, not allow the children to be able to have access to any drugs that they might be using, or Suboxone, or any dangerous drugs, and then resources for coal poison control right away if something like that happens.
And I think also, I think it's okay to, I'm sorry, I didn't mean to interrupt you.
Go ahead, Nikki.
Oh, I think it's okay to have rules too. I mean, I think if there's a community space, it would probably be not okay to have someone who is extremely inebriated on alcohol in that space if children were in that space, possibly. And so I think that if a building were to set that rule that, if you're visually intoxicated, then you need to be either in this particular space Or, I mean, it's better to obviously have a space where people are together or being can be monitored. You know, we don't want to send people to their room and then not go check on them for the overdose risk. But I guess what I'm saying is that I do think that it's okay to you know, have expectations if people are living in this building and are using drugs, that it should not negatively impact other members of the community, and that's, you know, a very doable goal, I think, for someone if they're given, you know, sort of what they need to make those choices. And everyone, you know, in the building deserves to feel comfortable. So having injection drug use in everyone's face is not necessarily going to make everyone comfortable. And I think that's an okay expectation too. And I think it's important in order to prevent people from, you know, feeling negative about people who use injection drugs, because if they're not negatively impacting your life, you're much more likely to be non-judgmental, I think. So, yeah.
Well, I wanted to just touch on something that I encounter, and I think maybe links a little bit to this. So I oftentimes people don't want to take Narcan, for example, because they say, no, I'm not using anymore, right? I'm not using anymore. I don't need Narcan. I don't want it. And so sometimes reframing it and providing information and safety information in a community-based way, as, you know, like the Getting Off Right book, right? Like if somebody sees that you have that, that's a pretty good indicator that you're using. But what can we do to provide to everybody, whether they're using or not, that doesn't call them out, right? Isn't a big sign above their head saying, hey, I'm using, that provides information about safety, whether you're using or not, and doesn't really call you out. Nikki, are you familiar with any books or brochures or things like that about, you know, kind of like being a good community member when there's drugs around?
Yeah, I can't think of anything off the top of my head, although I do think it's interwoven into a lot of harm reduction material. But I'll definitely, yeah, do some looking for that. I think that's a great thing to look for, and I bet it does exist.
And if not, maybe we could make one.
Yeah.
Oh, Shelley, yes.
So great discussion. I've had patients in and out. Sorry, so I will watch the recording of this. I would love Michelle to just share that I have started, so I got them off of their trainers. So it's something I got online. All my new patients, because I think the research now says 6 out of 10 Narcan administrations is given by someone not in the healthcare. And so I go at this, I want you to have it because you don't know who's going to walk in your door. And I say, and not just for you, I say that. So I want to make sure it's for someone in your home, but I say because, and then I actually take the trainer, because in my facility, this is what you know, it's not easy. It's not like this where it's easy to say this goes in the nose and it's one. So we take it apart and we practice. I show them how to do it when I say, yeah, so let's do it quickly. Here are the pieces. I put it back together. So that's kind of how I've gotten more Narcan in my patients' hands, because I tried really hard to make it about saving the community.
That's exactly right. That's wonderful. And I think that having those conversations, I mean, what I've noticed, it's empowering for patients to feel that they can, you know, that like so people who use drugs are so stigmatized, but but so many of our patients have such a sense of mission to help other people with this stuff. And if you can give them some tools and information around that, I found that they're very interested in carrying that forward, and very interested in carrying Narcan if it means it can help somebody else.
One thing I noticed, so we had some Narcan nasal spray for quite some time at the clinic, and we would offer it to people, and a lot of people would, you know, patients who come in for Suboxone and things like that, we obviously give prescriptions and we make sure they have Narcan, but offering it to just everybody in general, people would say no. Well, I decided one day to just put some out on the kind of donation community table. Those suckers were gone in half an hour. So just putting it out there for people to take, I was really impressed with how quickly those doses got taken.
I think something else that's helpful too is like Outreach got these like really nice cases. It has the NACC logo on it. It looks like a really fancy pencil case, but it's for Narcan. And we filled those with Narcan. We put instructions in there, and I've handed those out to people who don't use drugs. I've handed those out to people who do. And even just like the case, I think like the way it's wrapped is kind of like empowering to people. Like they're not just carrying around this like plastic bag, they're carrying around something really important. So I feel like that's something I've noticed. I think that's helped.
We are out of time, so I want to be respectful of everybody's time, but I very clearly an important discussion, and perhaps we could do this another time, because I think that it's worthwhile to continue to talk about it. And unlike some of the, a lot of the topics we talk about, you can find information elsewhere easily. I feel like this is not something that most medical professionals are trained in. So I think very important. Thank you so much, Nikki, for doing that presentation. And thank you everybody else for joining us. We'll see you next time, and it will be China and Simone talking about peer recovery. Thank you.
Thank you, everybody.
Take a love, man.